All right, welcome. We're about to fly through 15 medical mysteries in just 5 minutes. Yeah, you heard that right. The clock is already ticking, so let's dive straight in.
So, think you can keep up? This is a full-on diagnostic gauntlet. I'm going to give you the clues, and your job is to try and crack the case before I spill the beans. You ready? Let's do this. The clock starts now. Okay, here's how it's going to work. We've got 3 super quick rounds. First, we're decoding lab results. Then, we'll be reading the body's own signs. And we'll finish up with some real nail-biters, cases where you're racing against the clock. Let's get to it. All right, round 1. These are the cases where the answer is hiding right there in the numbers. You just got to know where to look. First case up, you've got a patient with high blood pressure and, importantly, low potassium. Now, that specific combo should make you think about aldosterone. You know, the hormone that handles our salt and water balance. A quick lab test confirms it. It's primary hyperaldosteronism. The diagnosis? Bilateral adrenal hyperplasia. And the go-to treatment is eplerenone, which blocks that aldosterone, and it's just got way fewer side effects than the older meds. Okay, next up. A patient with sickle cell disease comes in and they are severely anemic. Now, your first thought might be, okay, their red blood cells are just breaking down again. But wait, the real clue is in the labs. You look at their reticulocyte count. That's the number of new red blood cells being made, and it's shockingly low. That tells you the bone marrow has basically just stopped working. It's a classic aplastic crisis, usually triggered by parvovirus B19. All right, time for a quick pop quiz. A patient is on high-dose steroids, and their white blood cell count is sky high. But here's the thing. There are 0 signs of infection. No fever, nothing. So what in the world is going on? This one's a bit of a trick question. The answer has a fancy name, demargination. Basically, what happens is the steroids cause all the neutrophils that are usually just chilling on the walls of the blood vessels to just let go. They all rush into circulation at once, making it look like the white count is through the roof. It's totally a fake out. The body isn't making new cells, it's just a flash mob of the cells that were already there. Okay, check this out. You see a lab panel with this classic pattern: low blood pressure, low sodium, but high potassium. That combination should be screaming one thing at you: primary adrenal insufficiency, or Addison's disease. So how do you confirm it? You do what's called a stimulation test. You give them a shot of synthetic ACTH. That's the stuff that's supposed to tell the adrenal glands to wake up and work. If the cortisol level doesn't budge, well, there's your diagnosis.
And just like that, it's time for round 2. For this next batch of cases, forget the lab printouts. All the clues we need are in the physical exam, what you can actually see, hear, and feel. So, picture this. You're examining a patient who's short of breath. You start percussing their chest, tapping on it, and on one side, instead of that normal, hollow, drum-like sound, you just hear this thud, a dull thud. What does that immediately tell you? That dull sound, that's everything. That tells you you're tapping over fluid. It's a pleural effusion. Because think about it. If it were a collapsed lung, a pneumothorax, you'd hear the complete opposite. It'd be this loud, booming, hyper-resonant sound because you're tapping on air. I mean, how cool is that? One simple exam technique can point you to 2 totally opposite conditions. Here's a textbook case for you. An overweight teenage boy comes in with hip pain. So you go to examine him, and when you flex his hip up, his leg automatically rotates outward. That's not just a sign, that is a dead giveaway for slipped capital femoral epiphysis. We call it SCFE for short. And this is a true surgical emergency. The top of his thigh bone is literally slipping off. It has to be surgically pinned right away to stop the bone from dying, a condition called avascular necrosis. Okay, so how do you tell psoriatic arthritis from its more famous cousin, rheumatoid arthritis? Well, you just gotta know the clues. Psoriatic arthritis loves to hit the distal joints. I'm talking the very tips of your fingers, which RA usually leaves alone. On an X-ray, you'll see this classic pencil and cup shape. You'll also see changes in the nails and those puffy, swollen sausage fingers, which we call dactylitis. And the final nail in the coffin, the rheumatoid factor test will be negative. So a patient gets back from a great beach vacation, but they notice these white spots on their chest and back. They don't itch or anything. Now, this isn't vitiligo. It's actually tinea versicolor. It's caused by a yeast that's normally on our skin, but it just kind of overgrew. What's happening is that the yeast blocks the sun, so it prevents those spots from tanning. When the rest of the skin gets tan, the pale spots really pop. The fix? Super easy. Just a simple topical antifungal.
Now, here's a tricky one, because sometimes the right answer is to do, well, nothing. A patient has a milky discharge from both nipples, but critically, it's not bloody, and all her labs, even her prolactin levels, are totally normal. So what's the deal? It's often just from chronic stimulation. The official name is normal prolactinemic allochtoria, and really, the only treatment needed is reassurance. Now, if that discharge were only on one side, or if it was bloody, that's a whole different story. That's a huge red flag, and you'd need imaging, stat.
Okay, buckle up. This is the final round. And for these cases, it's not just about being right. It's about being right now. Time is everything.
Your patient has a nasty-looking pressure ulcer, and now they're confused and their blood pressure is tanking. This is sepsis, no question. And you have exactly 1 hour to get things under control. This is where the Hour 1 bundle comes in. It's your playbook. Yeah, you're going to measure lactate and get blood cultures, but the single most urgent thing you can do is slam them with broad-spectrum antibiotics while you start pumping in IV fluids. Every single minute you wait matters.
Okay, scenario. A patient steps on a rusty nail, and they have no idea when their last tetanus shot was. What do you do? Well, it all depends on the wound. If it's a relatively clean, minor cut, just the Tdap vaccine is fine. That'll build up their protection. But if that's a deep, dirty wound, now you've got to hit it with a 1-2 punch. The Tdap vaccine for long-term immunity, plus a shot of tetanus immune globulin to give them immediate protection.
I want you to look at this number, 80%. In vascular surgery, this number is a huge deal. It's the line in the sand that separates "let's just watch it" from "we need to operate." Any guesses what it could be? We're talking about the level of blockage in the carotid artery. If a patient has 0 symptoms, but their carotid artery is 80% or more blocked, just giving them statins and aspirin isn't going to cut it anymore. The risk of them having a massive stroke is just too high. They need a carotid endarterectomy to go in there and clean out that artery. It's a perfect example of preventative surgery. All right, last case. A kid comes in with what is obviously strep throat, but here's the catch. They had a severe allergic reaction to amoxicillin before. We're talking angioedema, breathing problems, the whole shebang. So penicillin is out. But here's what's tricky. You can't just switch to a cephalosporin because of the risk of cross-reactivity. So the correct, safe choice here is a macrolide, something like azithromycin.
Phew, we absolutely flew through those cases. So let's just quickly recap the most important pearls. For that sickle cell patient, remember, a low reticulocyte count is the key to diagnosing aplastic crisis. When you're examining a chest, percussion is your absolute best friend for telling fluid from air. In sepsis, nothing, and I mean nothing, is more important than getting those antibiotics in. And for that teenager with hip pain, you've got to get them to surgery immediately to prevent a permanent disability.
And that's our 5 minutes. We just ran a complete diagnostic gauntlet. You know, it just goes to show you, in medicine, knowing the facts is just the price of admission. The real skill is connecting those clues when the clock is ticking and the pressure's on. What's the next mystery you want to solve?